The information shared on the Sky Women's Health podcast is for educational and informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding your medical condition. Never disregard professional medical advice or delay in seeking it because of something you heard on this podcast. Reliance on any information provided by Sky Women's Health, Dr. Carolyn Moyers, or any guests featured on the podcast is solely at your own risk. You're listening to Sky Women's Health Podcast, your evidence-based resource for women's health and wellness, exploring the holistic principles of osteopathy, integrating mind, body, and spirit, designed to empower you as your own healthcare advocate and help you live your best life. I'm your host, board-certified OBGYN, Dr. Carolyn Moyers. Welcome back to Sky Women's Health Podcast. We are talking about real things affecting real women with no fluff and no shame. Today, I'm joined by one of my favorite people in pelvic medicine, the brilliant, compassionate, and straight-talking Dr. Nabila Noor. She is a board-certified urogynecologist and pelvic reconstruction surgeon, and your go-to expert on YouTube. You got to go look her up at Dr. Nabila Noor and follow her on YouTube. Subscribe to her channel. We're diving into all of the topics people are too embarrassed to bring up, but absolutely should. And we talk about it all the time in my office. So if you've ever asked yourself, is this normal when it comes to peeing your pants or having painful sex or feeling pelvic pressure, this is the episode for you. Welcome, Dr. Noor.
Thank you so much, Dr. Moyers. I am so excited to be a part of this conversation and really looking forward to it.
Yes. Well, I was kind of doing a deep dive on your YouTube channel, and what a wealth of information that you're providing in a very digestible way for patients. So I encourage everybody to go follow your YouTube channel to
Oh,
get
thank
all their
you.
information. Are you on Instagram and Facebook as well?
Yes, I'm everywhere. So
Okay.
YouTube is really my main source for long form videos because I kind of really do a little deep dive. And the way I kind of put it up, it's as if I'm talking to a patient. So it's very
Right.
easy to follow. It's not in depth, like hardcore research. We talk about what's evidence based versus not, but it's really meant for patients, really meant for not just patients, even family members to understand what these conditions are. And really, when I started it, my goal was to educate women, because I realized that what a lack of information there is regarding women's pelvic health. I mean, as like you mentioned, I'm a board certified urogynecologist, but my specialty really became a specialty in 2013, which is
Right.
very new. Yeah, just very new compared to some of the other branches of medicine, right? Even within OBGYN, which is your field as well. If you think about gynecologic oncology, you think about infertility, those have been established for a long time. And because we're so new, often people, even in healthcare, are not really familiar with what a urogynecologist does. And the more I'm talking about it, the more people are like, oh my God, is this a thing? There's treatment for this? And that's been really great.
Yes. Yes. So let's describe that then. Let's be very specific. So we have OBGYNs who have done additional years of training. And do we have board certification now for pelvic health?
We do, yes.
Okay.
So like you mentioned, right? So most of us after medical school, we decide on a residency. Now, for both you and me, our background is in OBGYN, so we did 4 years of residency. Now, after that, if I finished and went in and practiced, I could practice as a full scope OBGYN. So that's somebody, who's delivering babies, taking care of women's GYN health. But then I decided that I wanted to do some advanced training specifically to focus on women's pelvic floor issues. Now, the question becomes, what does pelvic floor issues necessarily mean? So it really encompasses a lot of things. The big things being, urinary leakage or problems with the bladder, bowel issues, right? Whether it's constipation or leaking stool, pelvic organ prolapse, where you essentially have all the pelvic organs pushing through the vaginal canal. Because I'm an OBGYN, I deal with a lot of trauma that women have after childbirth or during childbirth. And then a lot of women also have, pain with intercourse or, like menopausal care that they need. So there's a whole gamut of things that needs not just the specific focus of a gynecologist, but there's a lot of urology involved. So urologists are the specialists that take care of the bladder, the kidneys. But in my specialty, we learn a little bit about that. And also some aspects of what a colorectal surgeon does, because we're also dealing with bowels and stool issues and constipation. So as a urogynecologist or as a board certified urogynecologist and a pelvic reconstructive surgeon, so I went through 3 years of additional training to be able to get comfortable, diagnosing these, treating these, talking to women about these conditions. So that's where the specialty training is helpful.
Love it. So you are absolutely the person that we need to talk to today. And I hear
Now,
so
may I actually,
often,
sorry to interrupt you, but let me add
no,
one more bit. Now, I am a OBGYN going into urogynecology, but there are some urologists too that can do urogynecology and female reconstructive surgeons. So their background's a little bit different because as a
sure.
urologist, they are initially taking care of both men and women, but then they decide to focus on the female patient population. So sometimes, depending on which location you are in, your urogynecologist may have a urology background as well, and that's fine as well. As long as they're board certified and preferably fellowship trained, they are trained and they do have the necessary credentials to be able to take care of women.
Okay, fair point. Fair point. So oftentimes when seeing patients who've had pelvic surgery in the past, they're a little confused about what actually happened, what surgery was done.
Yes.
And this is one of the frustrating things for patients. Well, they're like, well, I don't actually know, and I have to get the operative note and review it and see what's going on, et cetera. So I love that we're going to kind of talk through a lot of these different issues. So let's start with uh, leaky urine. So the classic bladder leaks. Dr. Noor, what's the deal with stress versus urge incontinence? And why do they show up more around menopause?
Yeah, that's a great question. So, when we talk about urinary leakage, which essentially means that you cannot control your bladder, right? There are two big categories. And as you mentioned, one of them is what we call stress incontinence, which is essentially bladder leakage with laughing, coughing, sneezing, exercise, anything that puts stress, meaning pressure in your belly, not mental stress. Because a lot of the times patients will tell me, like, I'm not stressed. I'm like, no, 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 it's not that kind of stress. It's just stress, meaning pressure in your abdomen. Because what happens is when you put that pressure in your abdomen, that pressure gets transferred to your bladder. The bladder squeezes. Normally, the urethra, which is the pipe through which the urine comes out, that acts as a door and closes it so urine doesn't leak. But for women who have weak pelvic floor, the support to close the urethra is not as strong. So the urethra opens up, and as the bladder gets squeezed, all that urine just comes out. So that's the stress incontinence, and that happens because of an anatomical issue or anatomical weakness of the pelvic floor muscle. Then we have what we call overactive bladder. Now, these are your women who say, oh my God, Dr. Noor, when I have to go, like when that urge hits, I have to run that second because if I don't, I'll have an accident. Or I'm going every few hours, right? I'm going very frequently. I'm waking up at night to go to the bathroom and I cannot get a good night's sleep. Or, like, as soon as I hear water running or I put like a key in my door, the urine, that urge just comes in and there's no control and I have accidents and I'm embarrassed to go outside. So those symptoms are what we call overactive bladder. Now, majority of the women will have what we call stress incontinence, and we see that very commonly in young women. Like you mentioned, it starts probably around pregnancy, and then in the postpartum period, many women are noticing that they're still leaking when they're laughing, coughing, sneezing, and then it kind of prolongs and gets worse with menopause. Now, why is it getting worse with menopause? Because there's so many changes happening to our body. There are hormonal changes, right? You mentioned estrogen. Estrogen is a big what's the word? It's a big protectant for our pelvic floor. And what happens as women go through menopause is that we have a significant drop in our estrogen, and we have estrogen receptors in your vaginal tissue, in our bladder tissue, in your urethral tissue. And so when all that's deprived, those things are not working the right way. Now, a lot of women can have what we call mixed incontinence, which is they have stress incontinence and they also have overactive bladder. And again, menopause is a big risk factor, and we do see exacerbation of their symptoms around that time.
And Kegels are not always the answer.
Yes and no. Yes. So it really depends on what we're using it for, right? I think, we have for a very long time kind of equated pelvic floor exercises to just Kegel exercises. And yes, we do recommend Kegel exercises for strengthening your pelvic floor muscles. But what I think many times we don't realize is that the pelvic floor is a group of muscles and connective tissue as well, but it's really muscles. And the purpose of our muscles is just not to be strong. The muscles need to strengthen and flex. The muscle needs to relax and stretch. And all those functions are important depending on what's happening, right? So with Kegels, the idea is to strengthen your pelvic floor muscles. So a lot of women who are suffering with conditions that is caused by weak pelvic floor. So that could be your urinary incontinence, as we're talking about. It could be things like pelvic organ prolapse. Then for these conditions, yes, Kegel exercises can be great. But if you're somebody who is suffering with pelvic pain because you have very tight pelvic floor muscles and you
Wrong
have pain with
exercise.
sex, exactly. Like that's
Yeah.
the absolute wrong thing to do. So then the question becomes, well, how do I know if I need Kegel exercises or not? And that's where working with a urogynecologist or a pelvic floor physical therapist can be really beneficial, because the first step is to do a very thorough pelvic exam to know what is the condition that you're suffering with.
Agree. I could not agree more. And I would say that in a general OBGYN practice, because I did that for a decade, you just kind of look past all of that, right? You're going to do your pap
Well,
smear.
because you're doing with so much. Yeah.
So you're dealing with so much, and we just tend to ignore the vulva, the pelvic floor, nor were we trained really on how to address the pelvic floor. And so, through my involvement with the International Society for the Study of Women's Sexual Health, I've learned so
Yeah.
much more. And so my exams look very different now, where we're actually looking at the vulva, we're looking at that glans clitoris and the clitoral hood. I'm doing a digital exam for those pelvic floor muscles to kind of assess, so
Yeah.
that we can really know what's going on, because it's more than just, as simple as, oh, I can just do my Kegels.
Well, and I think, that's the beauty of your practice, right? I mean, I think you, as somebody who has practiced for a long time, you realize like, look, I'm not doing service to the patients who need this specific help, right? And that's why, you decided to create your practice so you could dedicate that time that your patients really need. And you absolutely, said it perfectly in a regular OBGYN practice. And that's really not to say it's the fault of anybody. It's just unfortunately the way our healthcare system is designed. I mean, if you're going to get a 15 and 20-minute slot to talk to a woman about everything that requires, discussion, you kind of
Sure.
try to prioritize like what's important, right? And so, looking at the vulva, looking at the pelvic floor muscles really is not on the top of your list. But having said that, that's why we have specialists right now, right? If there's a listener who maybe is in a place where they don't have access to somebody like you or like somebody like myself, you know, educate yourself, learn. There's so much information available. I mean, that's why I have all the social media platforms that I have, is really because there's so much women and patients and even people who just want to know about their body can learn from good resources, so that by the time they come to me, you know they're like, okay, I've already done all these like conservative stuff, Dr. Noor, I need something more involved. And it's a win-win for everybody, right? They're
Yeah.
not wasting their time. They've already tried some of the things that doesn't necessarily need my direct focus, but my guidance, which I'm already providing through all my platforms. And then we can really kind of take the treatment to the next level, depending on what their condition is.
Yeah, so let's talk about what some of those treatments are. So we addressed pelvic floor physical therapy. Let's not forget vaginal estrogen. Vaginal estrogen
Absolutely.
is a girl's best friend. Every vagina and
Yes.
urethra love
Yes,
estrogen.
absolutely.
Vaginal estrogen is safe for everyone. So I want to dispel that myth. We even have recent research looking at vaginal estrogen use in breast cancer survivors, and
Yeah.
there is no increased incidence of recurrence of mortality. Breast cancer is not a contraindication for using our low dose local intimate skin therapy with vaginal estrogen. It comes in in a cream and a tablet and a suppository and a ring. And then there's a nightly DHEA, which is a precursor to estrogen and testosterone that our vestibule
Absolutely.
absolutely loves. So these are all great options, especially if we're in that perimenopause, menopause transition, experiencing the dryness, discomfort, urgency, etc. So, talk to us about when it's time for surgery.
Yeah, that's a great question. I think it really depends on what your condition is. Something that I always tell my patients, especially when it comes to pelvic floor issues, is that, everything I do is quality of life. So there's no right or wrong answer. And what I mean by that is that, I have many patients who come to my office and they're like, Dr. Noor, I just want this fixed. We talk about like they know about the conservative stuff, but they're like, with my lifestyle, I don't have the time to kind of focus on the conservative measures because remember, the conservative measures are great, but they do take time, whether it be the exercises, whether it be medications. And so then for those patients, even on my first visit, we're talking about surgery, right? And then there are other patients, they come to me because they're just worried, what's happening to their body. And we do a full thorough exam. I tell them what their diagnosis is. And then we talk about all the options. And for them, they're like, okay, let me start with what's the most simple things that I can do. And so then we're focusing more on pelvic floor exercises. We're talking about lifestyle changes. And then, they give it some time, maybe a few months, maybe a few years. If things are not improving, that's when they want to consider surgery. So it really varies from patient to patient. One thing I will say though is because of my title, I have a very long title. It says female pelvic medicine and reconstructive surgery. So anytime like, a primary care doctor or their OBGYN would refer a patient to me, they see that title and they automatically get scared. They're like, oh my God, it's a surgeon. She only wants to do surgery. I don't want it. I will urge you that could not be the farthest from the truth. Your first visit with me, it's just like any other visit with your doctor. We're just doing a very detailed history. I'm trying to understand what it is that you're hoping to gain from this or from our visit and what would a better life look for you, like what is a good quality of life condition for you. We're going to do a very detailed exam to see what are some of the issues that you're dealing with, and then we come up with a plan that suits your particular lifestyle. So just because I'm a surgeon doesn't mean surgery is the only option that I'm going to offer you.
Right. And I think that's an important point. I often tell patients, I love to operate, but on the right patient for the right reason.
Absolutely. Yes. Yes. And I think, there's a
Yes.
misconception that, oh, surgeons just want to do surgery. I'm sure you hear it too, like when you're delivering babies, oh, they just want to do C-section. And that's not true. And I think that's where having a good relationship with your physician, trusting your physician, and it goes both ways, right? Part of
Sure.
my job is to educate, and I take that very seriously. And so I want my patients, when they're leaving my office, feeling comfortable that, hey, I understand the pathology, I understand my options, and I'm in charge of deciding what's best for me.
Yes, absolutely. Education is power. When you give women good information, they're going to make great decisions for themselves. So, one conservative option that I forgot to mention was a pessary and pessary fitting. And we'll get into this a little bit more whenever we talk about pelvic organ prolapse, but can you kind of describe what that is and what that looks like?
Yeah, I think before I do that, I do want to kind of just so that for listeners who are listening, we're talking about treatment options, but understand some of these treatment options are for very specific conditions, right? So when we're talking about urinary incontinence, which like we discussed is the leakage of urine, or if you're talking about something called pelvic organ prolapse, where you're essentially your pelvic organs, which could be the uterus, the bladder, the rectum, the intestines, are pushing through the vaginal canal. And what patients feel is this feeling of bulge and this ball coming out through the vaginal wall. So those two conditions can be treated conservatively with what you call a pessary. So a pessary is essentially a device. I mean, think of it as a vaginal insert. It's made up of silicone. They come in different shapes and sizes. The most common one that we use, it literally looks like a little ring, like a little donut. And the idea is you put the vaginal insert inside the vagina. And so for a patient that maybe have prolapse, with that vaginal insert in the vagina, you're pushing that bulge away. So removing that vaginal wall kind of protruding out and thus helping patients. Now, it is something that has to stay in the vagina all the time for it to be effective. So, for a lot of women, it may not be the best option. But I have many patients, who love it because again, it precludes them from having a surgery. It takes care of their symptoms. They feel comfortable managing it. Think about it as like having a tampon in. If fitted right, because they come in different shapes and sizes. So very important that we fit patients with the right size because you want the pessary to be big enough that it takes care of your symptoms, but not so big that it's rubbing against your vaginal walls and causing you discomfort and bleeding, because then you're not going to tolerate it. But once fitted, it should be like you shouldn't be aware of it on a daily basis. It's there, but it's you're still about like ready to go about your life. You do have to take it out and clean it periodically and reinsert it. I do tell my patients who are sexually active that it may be uncomfortable with intimacy, so maybe consider taking it out, kind of wash it after, and then reinsert it. But again, have patients who use it and who manage it themselves, they're pretty happy with it.
Yes, and, as you mentioned, pessaries come in all shapes and sizes and for different indications, and so in regards to stress urinary incontinence, there's actually a ring with a knob on it so that it actually supports that bladder neck that you were talking about. That support is weakened, and patients can use it specifically for the stress urinary incontinence. But as we start talking about prolapse and patients feeling that pressure or bulge or something's falling out of me, right? This could be the bladder, it could be the uterus, it could be the bowel, it could be multiple
Multiple
things
things.
all at
Yes,
once, right?
absolutely.
Yes. So, talk to us about the different types of prolapse symptoms, and then we'll get into our treatment options as well.
Yeah, for sure. So like I said, prolapse is when essentially your pelvic organs are essentially trying to push through the vaginal wall. Now, when we talk about our pelvic organs, which is basically the pelvis is our lower abdomen. So anything that's in that space can essentially push out through the vaginal wall if there's weakness of the pelvic floor. So I always tell patients, think of the vagina as a cylinder. And it sounds really weird. You're like, what? But essentially, the vagina has a top vaginal wall. And so on top of that, your bladder is sitting. You have the back vaginal wall. Behind that, you have the rectum, which is what collects our stool. And then, you have bowel movements with the anal opening and the apex of that cylinder. So the apex of the vagina is where you have your uterus and cervix. Now, depending on what area is coming out. So if the bladder is pushing into the vaginal wall and coming out, traditionally, we used to call it a cystocele, and now we call it an anterior wall prolapse because it's that anterior wall that's coming out. Similarly, if it's your rectum that's pushing through, traditionally we used to call it rectocele or the posterior wall coming out. And of course, if it's a uterus coming down, so it's a uterovaginal prolapse. And maybe for somebody who has had a prior hysterectomy, you can still have prolapse because a lot of the times I think patients are like, I don't have a uterus, what's coming out? So where the uterus used to be, we call that the vaginal apex or the vaginal cuff, that can come down as well. So depending on what part of the body is protruding out, we name it different things. But like you mentioned, sometimes it could be everything, right? So that's what we call a combination prolapse. And it's not as uncommon because, again, the etiology is the same. It's because of the weakness of the pelvic floor. So all those areas can essentially push out.
Talk to us about the risk factors for pelvic organ prolapse.
Yeah, so similar to urinary incontinence, there are many risk factors, but the common ones being age is a big risk factor, right? So menopause, like you mentioned, a lot of your patients are going through menopause because of those hormonal changes that our bodies go through. Childbirth, so multiparity, a lot of women who have had vaginal birth, specifically if you had any kind of instrumentation done at the time of delivery, like a forceps delivery, those are risk factors. Some of the health conditions, such as constipation. So my patients who are chronically constipated because they're always straining, so that constant pressure can put a lot of can cause those pelvic floor muscles to get weak. And similarly, women with chronic cough, so my asthmatics, my COPD patients, or being overweight. Anything that puts a lot of pressure can make those pelvic organ or make those pelvic floor muscles be weak and then end up with pelvic organ prolapse. And actually, I'll also say genetics. I have many patients who've never been pregnant, never had children or childbirth, and still have prolapse. And that's really from the genetics.
Yeah, that's a fair point. And when do you feel like we could correct this with pelvic physical therapy, pelvic floor physical therapy, versus it's time for surgery?
Yeah, and that really varies a little bit. Like I was mentioning before, it really depends on how bothered you are. So when do I notice that women first notice these conditions? So two important time in a woman's life. Number one is pregnancy and childbirth, and number two is that perimenopause menopause phase because your body is going through so much. So in the childbirth pregnancy related term, it's just the physical trauma, right? The physical act of having a vaginal delivery causes a lot of stretching on your pelvic floor muscles. If you have had lacerations or an episiotomy, it causes a lot of wear and tear. So that causes that weakness. So a lot of my postpartum mom in the immediate postpartum period is when they first notice these things. Now, for my young patients, I do tell them, especially if they're not done with childbirth, that, probably surgery is not the best option for you at this time. The reason is, if you're going to have a second child or you're going to end up with a third child and we've done surgery, it's not that we cannot. If we do, chances are it's going to cause more damage to that repair and then you may need a repeat surgery again. So for my younger patients who I know are probably not done with childbearing, I really do try to focus on more conservative measures, which could be pelvic floor exercises, which could be avoiding risk factors, which could be just in general improving their core strength. It's not just pelvic floor, it's not just Kegel exercises. You want to focus on your ab strength. You want to focus on your glutes, on your hips, strengthening those because you can't just work your muscles and expect that you're going to have a great body, right? So it's a focus on overall improving your strength and health. And then, in my perimenopause, menopausal patients, the conversation is more like, well, how much are you bothered by this? How aggressively do you want to treat it? Of course, people with more advanced stage prolapse, we didn't quite talk about it, but we actually grade prolapse, right? So you have anywhere
Right.
from stage 1 to stage 4. So stage 2 is kind of the midpoint where that bulge is coming right around the level of the vaginal opening. So, for my stage 3, stage 4 prolapse, those patients are really kind of feeling those symptoms. It's affecting them when they're walking, they're having that heaviness, pressure on the time. It's affecting how they empty their bladder, how they empty their bowels, with intimacy. So those patients really want something done more that's more definitive. And so we're talking about surgery. But for the stage 1, stage 2 prolapse, if patients want to be conservative, that's absolutely reasonable. And, we kind of see how they do with the conservative approaches. And if not improving, we can consider surgery.
Yeah, I love that approach. And I would agree. Stage one, stage two, if patients have not done pelvic floor physical therapy across the board, I tend to encourage that. And I have had, postpartum patients who had significant pelvic pressure, worse in the evening, when they've been on their feet all day,
Yeah,
even
absolutely.
up to, 8, 10 months postpartum, complaining of these symptoms, get them in a pelvic floor exercise regimen, and within 30 days those symptoms are gone. um, and a similar, I've had postmenopausal women with difficulty emptying their bladder with the urgency, etc., get them on vaginal estrogen, place a pessary, and voila, life is better. They're like, oh my goodness, I can empty my bladder with ease now. I'm not leaking when I cough, laugh, sneeze, etc. So, oftentimes, conservative measures can be extremely helpful, but there are definitely times when patients are like, I'm done. I need help, And certainly, if you have things falling out of your vagina, like nobody wants to live that way. That's a big quality of life. And not to mention, just embarrassing to many patients, right? Especially if we start thinking about intimacy.
Yeah, and I think that's something that I think we don't stress enough because to everybody's point, yes, a prolapse is not going to kill you. Urinary incontinence is not going to kill you. But like you mentioned, it really can have a significant impact on somebody's image about themselves, right? Whether it be
Sure.
body image, whether it be like, how conscious they feel. Like women are embarrassed. Like I have so many women, and they're young women as well as older women, who just don't want to be intimate with their partners anymore. They are stopping themselves from doing things that they used to enjoy. Like, when we talked about overactive bladder where women cannot control the urine when they have urgency. I mean, it doesn't sound like a big deal, but I mean, think about a woman who is petrified, to go out in a public space. I mean, I have many patients who are avoiding hanging out with friends, who are avoiding family vacations because they're so worried that if they don't find a bathroom, they're going to have an embarrassing accident. So I have patients who are literally preventing themselves from doing all the things they used to enjoy, like any kind of outdoor activities. And yes, it starts with like, okay, I'm not going to do this. I'm not going to do this. And before they know it, they've basically stopped themselves from doing all the things they used to enjoy, and they're miserable. They're miserable, miserable, miserable. They come to my office and have so many occasions where women have literally broken down because these are things you can't really share even with your loved ones, right? Because, you don't want to burden them. And especially a lot of women don't feel comfortable talking to their partners about this. And sometimes even their grown children, because they don't want to be that extra burden. And what they end up doing is just avoiding things altogether. And then the family doesn't understand, like, what's going on with mom? Like, what's going on with grandma? It's just
Right.
this vicious cycle,
Right.
you know?
And I've had many patients who they just weren't comfortable mentioning it to their primary OB/GYN or a male physician, right? To their primary care physician. They
Yeah.
just won't bring it up. So yeah, I think that's a very fair
Yeah, and
point.
that's why, like, I'm so glad we're doing this because a lot of the times women may not even know that these are things that actually have treatment. And that's the sad part because so often women are told this is just a normal part of aging. And yes, it's common as you age, but it's definitely not normal. I mean, that's something I talk about all the time, the difference between having something be common versus normalizing this. And that's a big difference.
Agree, agree. And that is such a great note for us to end on. Like it is, yes, it is common, but you do not have to suffer in silence. Pelvic health is
Absolutely.
foundational. And menopause doesn't have to mean leaking your pants and having pain and pressure.
Not at all.
Um, with the right care team and real information, you can laugh, lift, and love without limits.
Absolutely. And then women are doing it, thanks to all the advances, thanks to all the education, and even us as physicians, right? I mean, even a few years ago, menopause care looked very different than when it's looking now. And thankfully, this is a great time for both of us to be in this space because there's so many options that we can offer our patients, and it's really exciting.
Yeah, absolutely. I agree. Well, Dr. Noor, thank you so much for your wisdom and advocacy.
Thank you so much. I had a really fun time, and I really hope your audience benefits from all this. And absolutely, please check me out on the YouTube channel. It's really meant for education. And if there are questions and concerns that you have, please feel free to DM me and reach out.
Perfect. If you're struggling with pelvic symptoms, know you're not alone and you are not broken. You can visit me at Sky Women's Health or at Dr. Carolyn Moyers. And you can find Dr. Nabila Noor on all platforms at Dr. Nabila Noor. Please share this episode with your bestie, your sister, and your mom, and maybe a coworker, because every woman deserves to feel strong and supported in her body. Until next week, be well.